We are here at Harvard, and I'm very honored to be interviewing Professor Porter on our mutual interest on value-based healthcare. Professor Porter, last year you were in the Netherlands. You were discussing with us the value-based healthcare agenda in the Netherlands. There was a session made possible by Value-Based Healthcare Center Europe, Medtronic, and Amgen. We had a wonderful session, as you know. This year, what would you think would be the most important thing for us to discuss?
Well, of course, the value-based healthcare agenda is a complicated agenda, and it will be rolling out for many, many years to come. Because with value-based healthcare, you're never finished. You can always be better. You can always take it further. I think the things that hopefully we can start to make some progress on quickly are, first of all, really making outcomes required. And I think there's been a hesitancy to do that on the part of many governments, and even payers. They're private payers in the Netherlands. Payers have been very reluctant to do this, but I think now that we have ICHOM measures that are globally vetted by clinicians all over the world and standardized and published, I think the time has come to start making outcome measurement mandatory. And there's really two ways to do that. One is for the government to specify that, and the other is for the private payers to choose to go down that path. I think perhaps some combination of the two might be the best approach, but my view is there's no need for further delay in actually making outcomes part of every patient's care. For most of the major conditions. Obviously, we don't have standards across every medical condition, but we have standards covering a lot of the disease burden. And so let's get started, where we have those standards, and then the standards are going to be rolled out. So I think that would be one key priority. I think we also have an opportunity to do something that you and I have not talked too much about in the past, but we in healthcare we locked in on process and structural measures because they were much easier to measure. Outcomes were complicated and controversial and scary to measure. But I think, and obviously we're making progress on outcome measures, but I think there's a new kind of structural measure and process measure sets that we could put in place. We have that to some extent in organ transplantation here in America. You have to essentially report that you have a multidisciplinary team. If you don't have a multidisciplinary team, you're not qualified. You have to specify and really demonstrate that you have actually met as a team and coordinated care. So I think if we took value-based thinking and the IPU model and translated that into a new generation of structural measures, I think we could make that whole process much more useful in stimulating the formation of IPUs across many, many more provider organizations. Now, to be more adventurous, we would also start specifying minimum volume standards. That if you are going to provide care for breast cancer, then you have to demonstrate that you have a certain minimum volume standard demonstrated in the literature. So the point is that we have the Joint Commission here in America. We have the International Joint Commission. We have a lot of healthcare organizations are put through torture to get certification. Right. What if we change the certification to be about value-based healthcare principles and IPU principles? I think that hopefully is a step that we can take. And there's a lot of conservatism in moving in this direction, but I'm hopeful that we can achieve that. I think the final thing that I would mention is I do believe there's been a lot of progress on forming IPUs. There's been a lot of progress on reimbursement reform. I think the goals of reimbursement reform are quite well understood, and I'm delighted that some of the payers, including private payers, are starting to be pioneers. Okay. The one area where I think value-based healthcare has come recently, I think we need to drive this much more rapidly, and that is in the whole field of primary care. In any healthcare system, we're going to need primary care. It's holistic. Every patient needs to have a primary care relationship, somebody to look at that individual's broader set of needs and be a guider and a quarterback in that process. Then we have specialty care for defined diseases or conditions or sets of conditions. I think we have really made a lot of progress on value-based healthcare for specialty care. But for primary care, it's still early days. We still have a very traditional view of primary care, a traditional primary care model that exists, really all over the world. A doctor, a nurse, an office, but we are starting to understand that we can bring value-based principles also to primary care. We've published a number of articles on that, but that is just rolling out now. And the key idea in value-based primary care, number one, is you've got to segment the patients. A primary care model can't take care of anybody with any problem. You've got people in primary care that are very healthy adults. They need a different set of services than people that are quite old and maybe have multiple morbidities or comorbidities. And that's different than a patient with a serious acute illness where the primary care practice has to be involved in supporting that patient through this difficult circumstance. So I'd like to see us start to identify and validate and develop these new kind of primary care delivery models. And we're starting to see some. We have a case I know you're familiar with called Oak Street Health,
that's
which
a very popular one in the Netherlands now, right?
and that case is really exhilarating to see how much value primary care could create if it defines its patient population and really develops a multidisciplinary process around that population. So I think we are starting to see a lot of primary care attention towards the very complex patients that are very expensive. And let's organize to provide care to very sick patients very, very efficiently, because we can do it a lot more efficiently. I think we need to learn about how to deal with other patient populations. And I also think we need to move away from kind of the traditional idea that primary care is only provided in a primary care physician's office. We're starting to see in this country the increasing use of sort of supplementary sites of care like the retail clinics that a Walgreens or a CVS will have, which are very low cost, which are primarily nurse practitioner driven care, not doctor driven care. They're close to home. You can go for your immunization. You can go to have your ears looked at if you've got an ear infection, and if you need something more, you can be stepped up. But I think we need to make healthcare more accessible, closer to home, and lower cost. We don't need this really expensive structure that we've built in the past for primary care. Hopefully, we'll see more innovation in that area.